All right, looks like we've got a nice group here. So thank you everybody for joining us for demystifying wrist pain with sort of nationally certified hand therapist Christine Clements. Christine Clements has been a hand therapist since 2000. Is that right, Christine?
Yes.
And
Mhm.
an occupational therapist for even longer. So she is really our expert when it comes to all things hand and wrist. A few just housekeeping items before we get started. There is a Q&A button on your screen. So if you have a question at any point during the webinar that you'd like Christine to answer at the end, you can click that Q&A button and submit a question anonymously anytime, and I'll keep track of those. Also, everybody who registered today will get a copy of the recorded version of this, so you'll be able to rewatch, or those who couldn't join us live will also get a recording to review. So with that, I'll turn it over to Christine, who's going to teach us all sorts of fun things. Thanks, Christine.
Hello, welcome everyone. I decided to do this webinar based on a couple of reasons, and one is I see a lot of people with wrist pain, specifically undiagnosed wrist pain. So it's near and dear to my heart. I worked with a surgeon for years and years who was an expert in the wrist, and I have to give credit where credit is due. He taught me a lot. So there's a few little tidbits I'd like to teach you guys. I'd like to talk about some things, but the wrist is an extraordinarily complex part of your body, I think. I think it's unique, it's phenomenal, it does really great things, but when it gets hurt, it baffles everybody. So bear with me here. The first couple of slides, we're going to go over some basic anatomy. Everybody says the wrist. What's the wrist? The wrist is actually made up of 8 small bones in 2 rows. They don't look like nice and even rows, but they kind of are. We're going to talk about that in a minute. So at the end of the long bones of your forearm, the radius and ulna, you have 2 rows of little sugar cube sized bones, and then the back of your hand bones. So we're going to touch briefly on a couple things. This is actually called the proximal radial carpal row, the mid carpal row, and the distal carpal row. I wasn't very clear. The proximal row, the middle row, and the distal row, and they all have functions. Together, they make this structure that supports the use of the hand, transmits load back to the bigger areas of your body. So the wrist is an amazing, amazing concept. It has some really nice motion associated with it. It can bring your hand down, bring your hand back, bring your hand side to side, and then assist in articulates with your forearm to get supination and pronation. Basically, what the wrist does is it positions your hand so then you can do work like taking out a light bulb, or it positions your hand so you can write, or it positions your hand so you can get something out of a jar or a small box. The stability here is essential for function out here. Also allows you to weight bear, transmit those forces to the big muscles so they can take it a little bit better. And again, one more thing, it just stabilizes for gripping. If you didn't have a stable wrist, or if you're at a painful wrist, if I measure you, chances are your grip strength has diminished. So like I mentioned earlier, the wrist flex, extends, and side-to-side motion. It assists the forearm with supination and pronation. Notice here in that picture, actually, the wrist is an extension, so they can provide some force using that tool. So wrist is a very important player here. Okay. You may hear the word radial deviation or adduction. That means the wrist is moving the hand towards your body. Abduction moves it away from our body. Abduction moves it away, or ulnar deviation. And then when I say the word supination, that's turning your forearm up, and pronation, turning your forearm down. Normal active range of motion is about 60 degrees in both directions. You have 20 degrees this way towards your thumb and 30 degrees this way towards your ulna. So when you say, oh, it doesn't bend as far, it's not supposed to. This one bends a little bit better. But you can be very functional with a wrist that only goes a little bit as long as your elbow and shoulder work. So you have functional range of motion at a much smaller amount degrees than you do normal. Just a notation, your grip is the strongest when you have about 15 degrees of extension. So when you load your wrist a little bit backwards, that's where you're going to get the majority of your grip strength. So what goes wrong? What's the problem with the wrist? There is a big problem with the wrist, and that's that those two rows of little sugar cube bones sit next to each other very closely. They're tethered together with ligaments. So there's ligaments here, ligaments on both sides of the bones. They move very little, but they do move, and they contract for stability, they loosen for motion, but they stay pretty close to each other. The problem with the ligaments when they're torn, otherwise called a sprain, is the bones don't stay together, so they look like this on an X-ray, and when you go to move, the bones crash against each other. That's the problem with a ligament injury in the wrist. If anyone's ever heard seen the acronym FOOSH or heard of a FOOSH injury, it's a fallen and outstretched hand. So you're walking along on a icy winter day in Michigan, you fall and you can fall forward, hyperextend your wrist, or backwards to try to catch yourself. You may be the driver of a car that hits something and there's a hyperextension injury. All those things can happen without you really realizing you've done something bad. And I'll just give you an example. Let's say you fell on the ice last winter and you've had pain in the wrist ever since. You did go to the ER and they said you don't have a fracture, so you're fine, just go home. The problem is if you tore that ligament, stretch the ligament, or partially, stretched it out, you can still have lingering problems because those bones aren't staying together. They're crashing against their neighbors. So we'll talk about what you do to get a diagnosis. Anyhow, ligament injuries are typically fallen and outstretched hand or a hyperextension injury against force. The carpal bones, that's what we're talking about. When you say wrist, we're talking about those two rows of little carpal bones. They can not only dislocate, get out of their space and into somebody else's space, causing problems, they can fracture. So you're going to hear words like scaphoid, lunate, triquetral. They're going to refer to each bone by its name. You may experience, if you have a fracture, well, actually even a torn ligament, bruising, pain, swelling, weakness, limitations in motion. So don't be surprised if you have any of those things or all of those things. Of course, the evil arthritis rears its ugly head in wrist problems, diagnoses. And all that means is, I don't know if you can see here this white coating at the end of each one of these joints. You should have it here too. You should actually have it everywhere one bone touches his neighbor. And in this case, this is arthritis. This is what arthritis does. It bites away that cartilaginous surface, which is a smooth glass-like surface, and it makes it mean and bitey like that. You have osteophytes in there, pieces of bone. So think about this smooth motion that typically occurs with that glass-like surface, and then you turn it into this and try and still do the same motion. It hurts. But that's the ill effects of arthritis. You can get that primarily from osteoarthritis, but rheumatoid arthritis is a big player too. Again, pain, weakness, deformity. So what else happens? Well, you can have infection. You can have something that causes an imbalance in the soft tissue that crosses the wrist. Let's digress for a minute. Your extensors and your flexors all start up here. You have a big meaty mass. It skinnies on down to tendons. So your hand isn't big and fat like your forearm or arm, and it connects to the bones. So that tendon that scoots down to raise your thumb, for example, the tendon that scoots down here, he goes through a series of pulleys along his way. And sometimes So it looks like this. Your tendon goes through the pulleys with no problem. Sometimes that tendon gets inflamed and he tries to jump through that pulley when you flex your hand. And every time he does, he gets more swollen and you can end up with chronic cellular changes. Anyhow, that could be the tendon. Typically, it's the tendon sheath becomes inflamed. There's an imbalance and things don't glide the way they normally do. So people complain of wrist pain, and it's actually something called Duquervains, which is an imbalance of the size of the tendon going through the pulleys on the distal radial side of the hand like that. We'll talk about that a little bit more. So you need to be evaluated. Some of the things somebody might do is turn your hand back and forth and find out if something called the TFCC, I didn't talk about that. The radius and the ulna are stuck together by a ligament just underneath those two rows right here. And it helps you supinate and pronate. It's called the TFCC. So if you isolate your forearm next to your body and you are resisted in supination or pronation, or if you have painful supination and pronation, it could be a ligament injury called a TFCC injury. I'm going to show you a picture of something called a Watson shift test. That's where I would actually hold one of the bones still, called the scaphoid, and then move your hand and see if it pops or clunks when I let it go. That would also indicate that there may be a ligament injury. There's some simple tests, like putting your hands on the table. I'll show you a picture in a sec, and just bearing your weight through your hands. That's indicative of something called a scapholunate dissociation, where those two bones aren't together like they're supposed to be, and one goes this way while you're putting weight on it, and it hurts. So the TFCC I was just talking about right here, it's a little ligament that is only in this area, and if you didn't have that there, you wouldn't be able to supinate and pronate, or if it was stretched out, it'd be difficult to do. So if you have pain with supination and pronation, that's a big deal. This test here is actually called the Watson shift test, where you hold the scaphoid still. A therapist would have to do this for you. You can't do it on yourself. I suppose you could Google it and try it, but it's a difficult test to perform. And anyhow, the scaphoid is held still, and the other hand moves the wrist back and forth, and you can get some information related to the scaphoid there. Here's the tabletop test that I mentioned earlier. If you're having wrist pain and you put both hands on the table and put your weight through your hands, try and push yourself up, putting your weight through your hands, that's going to give you pain, or you can't do it, you cave. That's going to tell you that those ligaments aren't contracting and relaxing. They're letting a bone move out of its way. So all these things kind of indicate possibilities. There's more tests. There's diagnostics your doctor can order to confirm these things. This is my favorite. It's a cheap, easy test. It's called a clenched fist view. So most people, after I examine them, not most, but a lot, I talk to their physicians and say, would you consider ordering a clenched fist view x-ray? It's not a regular x-ray. It's not a regular x-ray in its positioning. It's a regular x-ray. So typically when you're x-rayed this way, obliquely, and laterally. What I suggest is you make a fist and you ulnarly deviate. What that does is under pressure during the test, you put pressure on it by deviating it, and you see the two bones sitting like this instead of like this. So this is my go-to for wrist pain that I suspect there may be a ligamentous injury or a fracture. Everybody says, don't I need an MRI? Don't I need a CT? What about a bone scan or an arthrogram? You know, all those tests have their role, and often patients get them. But the cheapest, easiest way to get you on your way to find out if there may be an issue with your wrist is to do the clenched fist view x-ray. Easy. There's a word down there, arthroscopy. Down the road, when the physician thinks that you've got something worth looking at, they can actually go in like they do your knee or your shoulder with ports, and there's a camera. and they can look at every ligament in the wrist. They just move it around and they take a look inside at every ligament to see what the integrity is. But that's down the road. Cheapest, easiest x-ray with wrist pain is to do a clenched fist view, and then you're going to know a whole lot about those carpal bones. Remember I talked earlier about when the tendon sheath gets inflamed? This is a test, it's called a Finkelstein's test, to see if you have de Quervain syndrome. So you actually bend your thumb down. This picture isn't exactly how it's supposed to be, but bend your thumb down, close your fingers over your thumb, and deviate the wrist ulnarly. You should have pain right there. And most people are going to pull their hand back before you're even halfway done because it hurts. So Finkelstein's test for de Quervain's inflammation of that tendon sheath is to have the thumb flex, the fingers around it, and then you passively go this way. It's pretty good at diagnosing it. Also, when you're going to see a therapist or see me, I'm going to look at things, trends. I'm going to look at things along the way. Say, what is our strength like? I mean, do you squeeze 85 pounds on the non-affected hand and 12 on the affected hand? Is your motion, instead of being 60, limited to 20 degrees? We're going to compare, hopefully you haven't injured both, unaffected hand, and see, where the trends are, where the flags are. When I examine a patient, I look for more than just what you told me, a fallen and outstretched hand. I'm going to examine you and see if I can find any sensory deficits, vascular deficits. There's a lot involved in my evaluation. But another test is called a Durkheim's test. If you have numbness in your hand, a lot of people think some of the nerve entrapments are related to carpal instabilities, and I guess they can be in a way, but typically things like carpal tunnel syndrome, that's a little different. We can talk about that. But Durkheim's test is where you actually put pressure over the carpal canal. See that big line that goes through your hand? Not down here, but right up here. If you put pressure on that, give your wrist a little bit of flexion, and if your fingers go numb, this one, this one, this one, and the radial side of this one, that means you have carpal tunnel syndrome. So not necessarily a wrist injury, even though the carpal canal makes up the tunnel that the nerve goes through, but it's a nerve entrapment. Okay, so that's what the Durkheim's test is. When it comes to, again, carpal tunnel syndrome, there are tests called Phelan's test and reverse Phelan's test. Both of those tests increase the pressure in that carpal canal and make these fingers go numb. Again, this guy, this guy, this guy, and this half of this guy. That's carpal tunnel syndrome, numbness, tingling, picking. If you have numbness in this guy and this half of this guy, that's the ulnar nerve. And typically that's entrapped at your elbow. So those are the two tests I talked about, Phelan's and reverse Phelan's on the right, and the Durkheim's test on the left. More or less. I'd probably flex that wrist a little bit more. Okay, so what do? I have an injury. I fell off my bike. I slipped on the ice. What do I do myself before I need to get into a lot of diagnostics or referral to a therapist? First thing is rest. If it's swollen, you're going to want to rest with your hand elevated above the level of your heart. So pillows, the back of the couch, whatever the case is. You're going to use an ice pack for the first 24 hours. That picture shows you putting the ice pack right on your skin. Don't do that. Use a barrier like a pillowcase, something thin. But anyhow, you can use ice for the first 24 hours. I like heat. I'm an advocate of heat. So if the acute swelling is getting behind you, heat helps you move, makes the tissues more elastic, more amenable to stretch, and it's very, very beneficial. Easy peasy way of heating the wrist is to make a rice sock. White athletic sock, 3/4 of the way filled with dry rice, not the top. Put it in your microwave for a minute, shake it up, put it in the microwave for another minute, shake it up. Don't go over 3 minutes. That's plenty, between 2 and 3. Wrap it around your wrist a little bit. Heat helps pain. You can use a heating pad, but not on hot. And the reason I'm drawing your attention to that is because people use it on high, I should say, not hot, high. And then your body's response is, oh my God, I'm being burned. I need to send more cells down there to cool it so I don't get hurt. So don't do that. Low, medium at the most, okay, with a heating pad. Warm water soaks. It's not as hot as I can stand. It's barely over body temperature. I love a home paraffin unit. That's where you have melted heat and melted paraffin wax and mineral oil, and you dip your hand in it, come out, let it stop dripping, and do it again. Put about 10 layers on, cover it with a grocery bag, and then a big towel or even an oven mitt. Feels delicious. It's easy, especially if you have arthritis. It's a great modality to use. I'm an advocate of compression gloves, not high tension. We use kind of wimpy compression gloves, but they trap in your body heat and they help reduce some of the swelling. I just had a guy come in here 2 days ago. He wrapped his own ace wrap and he literally was strangling his hand. He had this big, huge, brawny outpouching of swelling because the ace wrap was so tight here, it pushed it all this way. I don't even have ace wraps in the clinic because most people can't wrap them, but we do like gentle compression gloves. You see one up top, if I had an arthritic patient, I would use a 3/4 finger glove during the day because all day long you're snatching up your body heat that you're giving to the environment. You might as well keep it for your hands, and that gentle warmth and compression makes your hands feel really good. I also use a full finger glove at night. That kind of holds in more of your body heat. I like it better, but most people can't work with something like that. So 2 options, lots of stuff on the internet. Amazon sells a glove called iMac, I-M-A-K. It's advertised for arthritics. It's 3/4 fingers. It's pretty good. Anyhow, the rice sock in the bottom right corner, dry rice, an athletic sock, no big deal. And then that paraffin unit I was talking about, I usually go somewhere between 8 and 10 layers, cover it with plastic, and then either a towel or a mitt. So if your doctor says, and if you're healthy enough to take ibuprofen, it's an anti-inflammatory, you can do that for pain control, but this is what I caution people all the time. Don't just take it and then wait for your pain to spike and take it again. Take it as it's indicated every 4 or 6 hours for the first couple of days to keep that pain level consistent. If you wait, you bottom out and you spike, then the drug wears off, you bottom out, you spike. So try and keep that level consistent for a couple of days. You can wear a wrist splint, but I'm going to warn you, the longer you wear it without moving, the more stiff you get. So you need to wear it cautiously and for short term. Once the symptoms start to resolve, get rid of the wrist splint. If you still have trouble, you can use a wrist wrap for comfort, neutral warmth. I'll show you a picture of that, and it allows you to move better. And then try to return to normal activities as soon as you can with a gradual increase of weights or resistance. So the one on the right is a wrist splint you can buy on Amazon for about $10 or Rite Aid or Myers. It prevents the wrist, keeps you pretty stable, but you can still move this way, but you can't move this way. They fit most people pretty well. They're padded. They're generally pretty comfortable. It's called a wrist cock-up splint. The wrist wrap on the left, I don't think you can read the writing, but it actually says Fabrifoam, Fabrifoam. It's a company that makes these, and the inside, which you can't see, is a non-skid, sort of occlusive, just a delicious feel to this thing. You wrap it around your wrist, you can still move, yet it provides gentle compression and neutral warmth. We use them a lot here. They don't last long term, but they do give you some nice comfort along the way. So when do you come and see a therapist? I'm going to give you a rule of thumb. Pain doesn't resolve in 2 weeks. I'm going to give you a little caveat, though, before I'm done about that 2-week time period. If the pain is getting worse or it keeps coming back, if you have numbness is not normal. Numbness can be shut down by swelling because something else happened, or it could have been entrapped for a variety of reasons. Numbness is not normal, so don't think it is. If somebody's diagnosed you with a fracture or a dislocation, there's things we can do for that. And when you have arthritis, I like to treat arthritics. I really do. I was talking about this morning how the arthritic personality, these people just don't complain. They have these horrible deformities or these worn out joints, and they're so easy and lovely to work with. So I really enjoy my arthritics. I don't see people 3 times a week for 4 weeks. I see them for a few sessions, give them the tools so they can become independent. That works out well. Quick notation, and I said I was going to say something about 2 weeks and a carpal fracture. The scaphoid, if you go back and look at my pictures at the beginning, the scaphoid is a bone that crosses both rows, the proximal row and the distal row. He actually is the most dynamic of the wrist bones. And when you extend your wrist, he kind of leans back and goes with that row. And when you flex your wrist, he bows forward. So he's dynamic. There's a problem with the scaphoid just by design. All the carpal bones, their blood supply comes proximally to distally, so they get blood supply, each little bone. The scaphoid's blood supply comes distally and gives him supply. Everybody else gets it this way. It's it this way. Scaphoid's unique, his blood supply comes in distally. And that's a problem, because if you break your scaphoid through its waist, this part of your bone can die if not diagnosed. So if you get x-rayed on day 1 and 2 weeks later you still have pretty miserable pain, you might talk with your provider and ask to have your wrist re-x-rayed. And within 2 weeks, it'll show that that bone isn't getting the blood supply it's supposed to. So the scaphoid's a little different. Anyhow, when you need to see a therapist, all these things will give you an idea. Maybe I need a little bit of help, okay? How can you prevent wrist injuries? Good luck. You can wear your wrist splints when you're rollerblading or ice skating. There's not a lot you can do, but there are some things like, for example, warming up before you start your sport. So the typical prevention, there's not a lot you can do, but you can wear splints for sports. This is kind of a silly slide, but I put it in because I've become a Lions fan just when Lions got cool, I started paying attention. If you watch a football game, it's rare to see these guys falling or catching themselves on an outstretched hand. They use their shoulder, they use their hip. I'm not saying you can control a fall, because you can't, but I just want you to be cognizant of the fact if you can limit the situations that your hand is outstretched and your body weight is falling on it, it's worthwhile. So what are the things you can do? You've got arthritis, or you have a fracture, or you've been restricted against normal activities for a while. What can you do? I'm gonna show you some pictures in a minute. But there's something called DISM. It's silicone sheeting. It looks like, if you've ever kind of seen that drawer liner for toolboxes, you put it in there and then your tools don't jiggle around. It's silicone sheeting. It feels a little sticky. If you get some of that and just cut pieces of it and have it in your home where things are difficult. Lady this morning, I gave her a piece of Dyson because she can't, or she has difficulty opening the top on her detergent bottle. So she's got it sitting right there. Well, I gave it to her the other day, sitting right there on her shelf. So she picks up her detergent bottle, she puts it between her hand and the bottle top, and then that causes a little friction and makes unscrewing the top easier. So Dyson's a wonderful product. You can get it on Amazon in a roll. It's not that expensive. There's a padding called Acton padding. I use this with my arthritics who use walkers and a cane. When you weight bear on that painful, worn out wrist, it hurts. So Acton padding is actually fairly thick, but the beauty of it is you can weight bear and it's going to give relief from those bony prominences. It's wonderful for things you can't change, like using a walker or a cane. So I do use that. There's something called cylindrical foam. If you have trouble writing, what I usually tell people is to use a gel pen for one thing. Don't use a regular pen. It's harder for pinch and prehension. Remember, the wrist has to back up like this when you write and then hold these things in place while your hand does the work. So cylindrical foam, you put it on the pen, and now it's a wider barrel. You don't have to pinch so hard. So it feels good for arthritic wrists or painful wrists. If you're going to be doing things with your hands, I know they make gloves with non-skid polymer surfaces to help you grip. Remember, when you increase the friction, you have to grip less or pinch less. And then there's all sorts of stuff out there with ergonomic design, different handles. So that's some of the aids. I'm going to show you some pictures in a minute. But when it comes to techniques, and I think somebody asked a question to Kate earlier about this, what do you do about lifting? I recommend right off the bat, especially for arthritics, bilateral supinated lifting. So don't reach out for those grocery bags in your trunk and pick up 3 or 4 of them to walk in the house. You use a paper bag or one of your reusable bags, and you put one hand under and the other hand around it and carry it, or try and lift with both hands at once. You're recruiting your forearm strength. The other thing is, if you can somehow, which is tricky depending on what you do, but if you gently increase wrist extension to do the job about 30 degrees, that's where you're the strongest. Talked about that earlier. And there's a ton of stuff on the internet. If you Google joint protection, energy conservation, or work simplification principles, they'll give you all sorts of information. So here's another example. And I keep talking about arthritics, but it works for painful wrists. Let's say at home you have your dishes at home are those heavy, I don't know what they're called, crockware, heavy plates, and you're picking that up away from your body, out from a cupboard. You're gonna have pain in your wrist. If you swap those out and get Corel lightweight dishes, and you grab it out of your cupboard and bring it down, you've just diminished some of the effort for your wrist. So there's all sorts of ways to still get the job done, but do it just a little bit more differently and a little more safely. Here's another example. I think somebody asked a question about pain starting at their hand and running up to the elbow. What do they do about that? So I'd have to investigate and find out what it was. But if that was a lingering issue and it wasn't going away, cutting is hard and it causes pain. It can cause pain all the way up to your elbow. So this is a picture of, there's 2 pictures of rocker knives where you actually set your knife down on your food and you move your elbow back and forth, then move the knife, elbow back and forth. They work pretty well. That on your lower left is Dyson. It's that non-skid silicone sheeting. We actually just recently bought another product called Grippy that's a little darker purple. It's not as good as Dyson, but it's a lot cheaper and it works fairly well. So just FYI. On your left is cylindrical foam. So if you say, I have a hard time combing my hair, brushing my hair, you can get cylindrical foam in different diameters, build up that handle, and this is a lot easier to use than a small, tight, sustained fist. You can use smaller diameters to put on your pens or pencils if you want. I mentioned in an earlier slide pipe insulation. So let's say you have trouble with a broom or a rake. If you put pipe insulation that you can just get from Home Depot or Menards, the handle's bigger, doesn't hurt as much. So you can use that on different tools. And then on your right is just some gloves with a non-skid surface. There's actually a really interesting product. I'm not even sure what it's called, but it's a set of gloves with coarse, I don't know if it's silicone or what it is, embedded in the gloves. So if you have trouble peeling, like potatoes or carrots, you put these gloves on, and when you just rub the thing underwater, it peels your vegetables for you. It's actually pretty good. Works pretty well. I've tried it. So I get a lot of people who do certain things when they come in and they tell me they have pain because they've done these things. I'm like, yep, yep, let's look at your ligaments in your wrist because I bet that's what's causing it. So I have had several quilters as patients. And one of the problems with quilting, when you see all of these positions, they're all not very dramatic, but you're actually pulling that rotary cutter against resistance with sustained or resisted ulnar deviation, or in some cases, this one is an extension over here on the left. Just depends how you're using your tools. This is just an example. Well, what do you do about that? You still want to quilt. I get it. But let's use a neutral wrist. There are products out there where you can modify things. Just like people who knit and crochet, people don't knit and crochet for 5 minutes at a time. You know, they're going to do it for an hour or 45 minutes. So one of the things that I always tell them is to take frequent breaks for one thing, but that sustained repetitive pinch and rotation of your wrist hurts. I can modify crocheters' needles. I can't do knitters because you put the thread on the needle. But there's all sort of adaptations I can make to fix, modify the grip on things you're using now that cause pain. That's just another side note. Okay, pickleball. At one point, I don't know, about 6, 8 months ago, I had 4 women at the same time with distal radius fractures from pickleball. My joke is don't ever play pickleball because it's dangerous. So I'm joking about that, but really there's some truth to it. Why would I have 4 women at the same time with distal radius fractures from pickleball? One of the women who I saw, who came in a little bit later with that group of 4, I said, "What is so bad about pickleball?" And she was a retired ER nurse. And she thought about it for a minute and she said, "With pickleball, you move laterally, and that's not a normal motion for people. So they trip and they fall on an outstretched wrist and break their distal radius." So I was doing a little research, Sam, and not that you shouldn't play pickleball, just warm up, make sure you're in good shape before you start moving in uncomfortable ways. But I did this little research, and it said here $400 million were dedicated in 2024 to rehabilitating and diagnosing and providing surgery to people with pickleball injuries. So be careful. Okay. Those are the main items I wanted to come across to everybody that I could think of. People might ask questions. I can certainly entertain those. But just know that if you have an injury or you have arthritis, you're not getting relief, there are things I can help you do to get relief. I'm not going to fix your arthritis, and I'm not going to make it go away. I'm not going to fix your scaphoid fracture. But I can do things along the way to make you more comfortable and regain your independence. So that's my goal.
Excellent. Thank you, Christine.
Well,
We did have just a couple questions come through, and I might have some questions for you later because apparently I have DeQuervains veins after that little
oh
test, so
no.
that's fun. Which I did not know. I've not had wrist pain, but that test sure gave
Oh
me some real
boy.
results.
Uh-oh.
Um, One person did ask, what are your thoughts on non-surgical treatment of, I'm going to try to say, I've read this word a lot, I've never said it, Dupuytren's
Oh,
fracture?
Dupuytren's.
Dupuytren's.
Um, it depends. The answer is if you have Dupuytren's disease, which is a thickening of the palmar fascia. So if you peel back the skin, there's a layer between your skin and the underlying tendons, and it's a thick, sinewy kind of layer. That's why you have padding on this side. You don't have any padding on this side. But there's something called a tabletop test. So if you take your hand and let's say, let me back up. DeQuervains, that palmar fascia shrinks and your fingers bend down. You may just have one, you may have two, you may have significant. You know when you need attention is when you can't pick these fingers up from the table anymore. It's called the tabletop test. But I'll be very honest, almost nothing works non-surgical for Dupuytren's in my experience. You're not going to win. That palmar fascia is diseased. Its job is to shrink over time. You don't know which finger it's going to attack. However, people have surgery to take that layer out. And if you haven't waited 40 years, which a lot of people do, we can straighten your fingers out once that palmar fascia has been resected. But there's a really awesome product. If you haven't heard of it, it's called Xiaflex. Starts with an X, Z or Xiaflex, and it's an injection. So the doctor takes that cord and he or she injects this medication. One day it's actually an enzyme. Next day you go back to his office and he pushes you straight and the cord breaks. So there's no surgical wound. I love Xiaflex as a procedure to fix Dupuytren's contracture. But your question is there anything non-surgical? Not that I've ever seen that works. If I splint you and try and straighten you out, I'm still battling an ongoing process that I can't win. So not much from this side in non-surgical or non-Xiaflex. Sorry, I wish I had one, but I don't.
Very helpful. Thank you. I do have 2 more questions in the queue. Anybody who's here with us live, there's still time to submit a question if you have one. So click the Q&A button. A couple of these questions might be kind of a review of what you already said, but I still want to ask them just to make sure everybody gets their question answered. So any home self-help or exercises for de Quervain's or just rest?
No, okay, so de Quervain's is mechanical friction is causing swelling. So you have to stop the friction. I don't know if you remember me saying this is normal. This is de Quervain's. So this nodule is too big for the tunnel. So you have to stop point A to point B. If you come and see me, I put you in a long thumb spica splint, leave this free, crosses your palm, crosses here, and you sit there depending on how long you've had it for probably close to 6 weeks. And it shuts down the total tendon excursion from point A to point B. So instead of doing this, you're only allowed to do this. And by doing this, you've reduced the mechanical friction that's causing the inflammation. I mean, I suppose you could go to the store and get a long thumb spica splint and put it on for 6 weeks, but there's more that I do than just splint you. I'm going to show you how to exercise once a day. I'm going to tell you how to do ice massage right here at the distal radial wrist where you have the trouble. But it's a waiting game, and it's a question of changing the friction, mechanical friction generated by an inflamed structure trying to go through a small one. You're not going to have a whole bunch of visits for a therapist, but you're going to have the visits that progress you in the protocol and tell you what to do when. But it's a waiting game of about 6 to 8 weeks, depending.
Sounds good. Thank you.
Mm-hmm.
The other question you kind of addressed earlier, but again, I just want to kind of review it. Someone said, I just started to have wrist pain that goes to my elbow. Should I seek medical care? It came out of nowhere.
Well, it depends how long it's lasted and what is causing it. So if you have pain with resisted wrist extension, I'd probably have it I'd take a look at. And besides that, you can't walk around with pain indefinitely. So you probably do want to have it screened and see if there's something going on. I'll tell you a quick story. I had a patient who fell, what was it? The night before his wedding or whatever it was, like 20 years ago, and had this bruising and horrible swelling, blah, blah, blah. Life went on, okay? So then he had another incident 10 years later, again to the same wrist, where he had a traumatic injury against resistance. So out of the blue, years later, because that ligament was probably not completely torn, but partially torn, he had yet a third incident and the ligament completely tore. So coming out of nowhere, this guy did have something coming out of nowhere, even though we could track back some trauma that had happened over the years. The answer is, I don't know. I'd probably have to take a look at you, but you shouldn't have to live with pain. So finding out the basics might be worth it. If you're arthritic, I can understand how that would happen. Suddenly, the cartilage is so worn down that the wrist says, I'm done. You guys need to help out. I can't do it anymore. So because the wrist isn't stable, it's going to translate that deficit to the elbow. So I'm not sure without taking a look at you, but you shouldn't have to live with pain if you haven't had a specific injury and you're not diagnosed with arthritis. I hope that helps.
That does help. Thank you. That's all the questions I saw come in. So thank you, Christine. I do just want to mention what's on the screen there, the locations where we offer certified hand therapy. Christine is at our Saginaw Bay Rd clinic, and she has 2 therapists who work with her as well who are pursuing their certified hand therapy certification. So that requires about 4,000 hours of direct practice experience in the hands, and then an additional extensive exam on top of it. So they're working through that. Again, Christine has been a hand therapist since the year 2000, so she's got some experience under her belt. And then we have Janet Frank at our Frankenmuth Clinic, who offers certified hand therapy. And we're also getting a therapist up and running at our Caro Hooper Street Clinic, who's working under Christine's mentorship as well. So she's kind of working toward that CHT over time also. And all of these locations offer a free 15-minute screening. So if you're not 100% sure if therapy is what you need, our therapist will always be very honest if they think you need to see a surgeon or therapy is not going to be the right first step for you. But that screening is definitely on the table for anybody who wants to learn more. So thank you, Christine. I love hearing you talk. You explain things so well. You're fun to watch too when you explain things, so I appreciate you doing this for us. And everyone who registered will also receive a follow-up email from me with some information and the recording for this in case you want to rewatch some things and see some of those products she recommended. So thank you again. Thanks everyone for joining us.
Bye-bye.
Bye.